my privilege to introduce my friend Dr. Shanmugasundar. He is speaking on the obesity topic. The MD General Medicine and DM Endocrine of obesity by Shanmugasundar. He is the best outgoing student in MBBS in 2003 to 2004. Formerly, and Tamil Nadu MGR Medical University Dr. Anatomy, AV Gandhi Award for Excellence in Endocrinology, Best Clinical Customer in Spot Case Diagnosis 2010. More than 15 national and international publications, authored some chapters in several textbooks. Consultant and Director, National Court.
I think it's a phone or either.
Consultant, Director, National Court. And he is for obesity, diabetes, and endocrinology, and consultant, AC Hospital, Medical College, and KKR. Welcome, Dr. Shanmugasundar. Please take.
Good afternoon, everyone. At the outset, I thank the organization for giving me this opportunity, and also thank Dr. Shanmugasundar for inviting me. So, what I am going to do in next 20 to 30 minutes is give a brief overview of the obesity. I am not going to bore you with the hypothalamus, pituitary, the neuron, the axis, the theoretical part. I am not going to discuss. So, briefly about the practical points. So, what are the important causes for obesity? What we should ask in the history in the when the obese people come to us, and what are the investigations to be done, and what are the therapeutic options available. So briefly about everything. Okay, so these are the things I am going to discuss. So the epidemiology, so what is the prevalence of obesity in India, and what are the different definitions, and what are the common causes, and how we have to work up for the treatable causes, and how to work up for the complications associated with obesity, and how to manage weight. So obesity, obesity is now considered as a chronic disease, like glucose metabolism. Disorders in glucose metabolism, we say it's a diabetes. Disorders in the blood pressure regulation, we call it as hypertension. Similarly, body weight is also a physiologically regulated parameter. So any disturbances in this, we call it as obesity. And many factors contribute to the development of obesity, so I will be discussing in the future. And basically, it's a long-term positive energy balance where the energy intake exceeds the energy expenditure. That is the main cause for overweight. So many of the patients which come to us is mainly the simple obesity. It's not going to be the hormonal cause of obesity, other things. So like Cushing syndrome or hypothyroidism, etc. But the concept is very, very important. The patient has to understand that they are in the positive energy balance that is leading to the overweight. As many people used to say they are not losing weight in spite of sincere effort and all, but this concept is very, very important. Unless the patient understands this concept, it's very difficult to treat the patient. So various definitions by BMI, body fat percentage, and waist circumference, we can define obesity. So this is the reference for the Asian Indians. So 18 to 23 kilograms per meter square, it's normal, and 23 to 25, we call it as overweight, and anything more than 25 is called as obesity. So Western guidelines are slightly different. You can add 2.5 to this, or to adjust this, either for definition or for the treatment decision. 2.5 plus to this is the guideline for the Western population. So body fat percentage, so to more than 25% for males and 30% for women, correlates with the BMI of 25 kilogram per meter square. And basically, this values correlates very well for the Western population, but the correlation is poor in the Asian Indians. And waist circumference for the Western population is different. For male it's 102 and the female 88. For the Asian Indians it's 90 and 80, because it is visceral fat is a surrogate marker of insulin resistance, and the more this chronic complications are more in Asian Indians. So our definition is different. So if you compare with other races, our visceral obesity intra-abdominal report is comparatively very high compared to the subcutaneous report, compared to the Caucasians and the black. That's why the definitions are slightly different in our population. And very important, in children, the criteria are different. So, the percentage we calculate in the percentage, not in the kilogram per meter square. For BMI, anything between 85 to 95%, we call it as overweight. call it as obesity. So we need to plot the BMI in the growth chart. We have the Indian specific growth chart, IAP growth chart for separate for the boys and girls. The blue color indicates boys and green color indicates girls. So we need to mark the BMI in this and we have to calculate the such rate. Accordingly, we need to classify whether it's overweight or obesity. So coming to the prevalence, just one slide I am showing. So this is from the JAPI 2012 by Sanjay Kaldra. So if you see the slightly good states like where there is plenty of nutrition etc. like Punjab, Kerala, Goa, Tamil Nadu, the prevalence is almost 20%, combining overweight and obesity. So Tamil Nadu ranks 4, both the male and female. So almost the percentage is 20% overweight and obesity prevalence in males and 25% in the females. So coming to the etiology and risk factors, what are the common causes? Briefly I will discuss it. So genetics, age and weight, lifestyle contributors, we know that this is one of the important things. And what are the medications which can lead to weight gain? What are the endocrine causes for weight gain? And other possible contributors to obesity and environmental. So genetics, very important. Genetic contributes to adult BMI 40 to 70%. If one of the parent is obese, there is a 3 to 4 fold increase in the risk of obesity compared to if both parents are not obese, then there is less risk. If both the biological parents have obesity, then there is a 10-fold increase in the risk of obesity in the offspring. So genetics plays a very important role. But usually the simple obesity, there is it's a polygenic. So multiple genes are involved. We know multiple genes are involved. But usually we don't do genetic testing in the simple obesity. Only in the syndromic obesity or monogenic obesity we do genetic testing. There are few monogenic and syndromic causes of obesity. But usually we can clinically also we can make the diagnosis. Usually the presence very early. Usually the obesity starts within the 1 year itself. At least before 5 years there will be a significant obesity. Most of this monogenic obesity done by 1 year itself. 6 months, 1 year itself, the baby will be very much obesity. So we can make the diagnosis in the by clinically itself, but if indicated, if the patient is affordable, we can go for the genetic testing. Other obesity syndrome, they will have associated other malformations. So,
if a child is obese and it's 3 years, he will be obese later on in life, is it?
Yeah, that will be coming. Is usually, even in the toddler stage, if the kid is obese, there is a 50 to 60%, the kid will be obese through the adolescent and adulthood also. So, risk increases.
But I have seen my girl was very thin, but after 25 years, she became very fat. So I don't know how this. Till 10 years, she was very thin.
That's common. That we discussed all those things. These are important points. So this is a natural thing which happens in our life. That I will be discussing in the next slide. So obesity syndrome, they will have other features also like Prader-Willi, Bardet-Biedl syndrome, etc. So coming to the another important thing, fetal and childhood factors. Very important. Most of this metabolic disorder starts from the intrauterine life itself. If the mother has diabetes, the mother is overweight, mother is underweight, there is a significant maternal weight gain during the pregnancy, all influences the baby. So the baby is at risk for obesity in the later life. So and also the IUG or large for gestational age. Again, this child also prone for obesity in the later age. And infancy and childhood. The breastfed child has a lesser risk of obesity compared to the kid which has not received breast milk. Almost 22% difference is there. And if the breastfeeding is for at least 7 months, again the chance of obesity is less compared to kid which has received only less than 7 months of breastfeeding. So all these things start from the early childhood itself. And as far as the early childhood, toddler stage also very important because it reflects the environment, the microenvironment around the babies. What is the food baby's child is taking? What is the physical activity the child is doing? So all those things are going to continue in the life also. So that also influences. So the intrauterine life, the maternal changes, and the infancy and early childhood are very important. Coming to the question, as I told, there is a weight gain. So usually adults tend to gradually gain weight between the age of 20 to 65 years. This is a study from US, prospective study. So healthy, normal weight US adults, they were taken 30 to 59 years, they followed this patient. So within 4 years, almost 14 to 19% of the female and 26-30% of the males become overweight, and almost 5 to 10% of the subjects develop obesity. And within 30 years, more than 50% of the population become overweight, and 30% of the females and 25% of the male develop obesity. So significant number. This is because when they did the energy calculation, They are just consuming 100 kilocalories extra per day. Nothing more than that. Just 100 kilocalories, but it's a cumulative effect. Gradually they are accumulating this calories, so they are gaining weight. So this is what happens. Usually you can see at the college days, most of us used to be lean. But if you see 40 years, everyone will be different. But the patient used to say, I used to be obese, same, lean, I'm doing the same thing, I'm taking the same diet, doing physical activity. But what happens in our clinical practice is, usually they under-report energy intake and over-report the physical activity. This is what happens usually. Any patient used to say this thing. Again, taking the history and counseling them is very, very important. Usually after 65 years, there used to be a weight fall at the rate of 0.65 kg per year. And pregnancy and weight gain, again data says that some patients, some pregnant ladies lose weight after delivery, but for certain patients, whatever the gain they had during pregnancy, that can persist, and they can have obesity after the pregnancy also, particularly if they have multiple pregnancies, then the case more. Menopause and weight gain, again very common at the age of 45 to 50, most of the women used to have weight gain during that time. So again, we don't know what is the cause, because some studies have shown even with estrogen replacement, people who have received estrogen replacement, there is no difference. With or without estrogen, there is a weight gain. From that, theoretically, they say increase in the FSH may be the reason for the weight gain. Again, menopause is an important risk factor for weight gain. Average weight gain may be around 3 kg, and waist circumference increase can be up to 6 cm during the menopause. So dietary factors, now we know that due to the lot of changes in our dietary pattern, again it's an important risk factor. Physical activity and inactivity, data says that 1 hour of extra watching television or mobile, there is a 13% increase in the obesity, particularly childhood obesity. Sleep pattern, even if you sleep for 7 hours or 8 hours, but if your sleep cycle is altered, that is if you are working in the night and if you are doing the night schedule and if you are sleeping late and waking morning late, also again the changes in the circadian rhythm can influence and they can have obesity. Smoking cessation also increases obesity. So probably the nicotine acts on the pro-biomelanocortin levels of the hypothalamus. So it increases the anorexic. So by smoking cessation, there can be 2 to 3 kg weight gain, and data says 10% of the people who stop smoking, there can be 10 kg weight gain also over the time. So again, smoking cessation is also an important risk factor for obesity. So medications, common medications are psychiatric agents, antidepressants. And coming to diabetes, insulin, glutazones and sulfonylureas can cause weight gain. And another thing is steroids, corticosteroids. So a lot of use of corticosteroids again can lead to weight gain, and progestational steroids, which is contained in the OC pills, again can lead to weight gain. So what do you think is the commonest cause, endocrine cause of obesity? Hypothyroidism, Cushing, genetic hypothalamic syndromes, none of the above. Hypothyroidism. Anyone else?
Commonest should be hypothyroidism.
Common is insulin resistance. Insulin resistance. That is the commonest cause of overweight. Most of the times, the subclinic hypothyroidism, all those things may not cause the obesity. In turn, obesity can lead to subclinic hypothyroidism. Usually, with weight loss, there will be decrease in the TSH levels. So usually, the slightly elevated TSH is not an indication for the treatment for subclinic hypothyroidism, but due to the obese population. So insulin resistance is a common cause. Again, the etiology is almost similar to the other things like family history of insulin resistance, physical inactivity, the food chain patterns, and mental stress leads to insulin resistance. I'm not going to detail. So hypothyroidism and weight gain. The severe hypothyroidism can lead to weight gain via body fat accumulation, fluid and sodium retention, and increased accumulation of this glycosaminoglycans glycans. Usually, the hyaluronic acid which accumulates due to this long-standing hypothyroidism, they attract water. They store water in the W attracts water, so there is accumulation of water. So with thyroxine therapy, usually this water restrictions happen, so there will be weight loss. So usually this fluid retention, whatever has happened, is lost by treating in the hypothyroidism. Cushing syndrome, again, important cause for obesity, but not very common. But main thing is there should be high clinical suspicion should be there. If you suspect the patient can have Cushing syndrome, always rule out Cushing syndrome. Very easy to do it. You can get an AM cortisol to rule out whether the patient is taking some exogenous steroid or not. Then do an overnight dexamethasone suppressor. Give 1 mg of dexamethasone at 11 p.m. and do an 8 AM cortisol next day. Values less than 1.8, then you can rule out Cushing syndrome. So always rule out Cushing syndrome if you have suspicion. It has to be distinguished from pseudo-Cushing. Sometimes morbid obesity and PCOS can have pseudo-Cushing, that has to be differentiated. Other hormonal causes for obesity are hypogonadism, growth hormone deficiency, hypothalamic obesity. Sometimes post-surgery for the hypothalamic region and pituitary region like craniopharyngioma, people can have obesity. Iatrogenic like diabetic, few drugs like diabetes or steroid therapy can lead to weight gain. So other possible contributors to obesity, gut microbe, but again data are conflicting, whether we don't know whether there's a direct causal effect is there, so we don't know. And lot of again endocrine disrupting chemicals like bisphenol A, perfluorant chemicals can lead to obesity, particularly in the children.
What is gut microbe?
Normal our microbe.
Yeah, what has it got to do with obesity?
So it has linked to many metabolic
Sir, a lot of link between brain and the gut. They have hypothalamic control.
So even the cardiovascular protection, lot of things are there. But we don't know whether by altering the gut microbiome whether there is improvement in the parameters. Many studies.
So we need the gut microbiome.
Yes. Alteration in the gut microbiome. Normal gut. There is a
Antibiotic-
difference in the
antibiotic.
obese people gut microbiome, normal weight gut microbiome, diabetes gut microbiome, and the non-diabetes gut microbiome. Lot of differences due to the alteration in this. It can influence with other parameters also. The inflammation, endocrine dysfunction, many things. Environmental factor, no need to discuss. If you want to discuss, we need a whole day. So it starts from the microenvironmental, from the siblings, parents, the surrounding structure, and the advertisements, school environmental, government rules, many things influence us. So mainly, they should have a proper home environmental. They should eat together. They should exercise together. They should sleep on time. There should be a good environment for the playing, etc. And it should not be like this, watching TV while eating, and they are not spending time together, and they are eating while they are seeing mobile while eating. And outside the home, there are a lot of opportunities to go for any junk food. Again, it's very common nowadays, and wherever you go, the advertisements are tempting to buy the things. So even if you pay some bills, you get an offer, 300 rupees off on pizza, Domino's pizza, everything. Everywhere if you go, you will get offers for this kind of things. So obesity associated complications. So many complications can happen like diabetes, dyslipidemia, cardiovascular disease. But obstructive sleep apnea, again very important. That history has to be asked in the patient with obesity. Musculoskeletal disorders like gout, osteoarthritis. Few cancers has been linked to obesity like endometrial, breast and colon. GIT, non-alcoholic steatohepatitis, fatty liver disease. Again very important. The trend is increasing very much. So in future we can see a lot of cirrhosis and clearly due to obesity. Gallstones, renal stone disease, urinary incontinence, infection. We know that COVID infection, many people, there is increase in mortality, particularly in obese population. So a lot of complications are due to obesity. Why it's important to know this is, while you are evaluating the patient, we need to know this. So we have to screen for the complications. So coming to evaluation, so when the patient with obesity comes to us, we have to investigate for the cause, any treatable cause is there. And also we need to see any obesity related health risk is there, and candidates for weight loss intervention. We need to segregate the patient. This is a low risk patient, this is a moderate risk patient, this is a high risk patient. So whether they require pharmacotherapy or only diet and physical activity, we need to segregate. So these are the three goals while evaluating the patients. So history, look for genetic predisposition, ask the family history, and physiological, ask for pregnancy, race and menopause, and we need to load endocrine abnormalities. So we need to ask those history. The physical activity, the dietary pattern, we have to take 24-hour recall dietary pattern, the sleep pattern, stress, depression, there are any drugs which can cause obesity, so all these should be taken. And clinical examination, BMI and waist circumference should be measured, and blood pressure should be measured for all the patients. So look for other stigmata like any stigmata for PCOS like hirsutism, acne, and look for stigmata for insulin resistance like acanthosis nigricans, visceral obesity, and also the Cushing stigmata. We need to look for those things. Evaluation, as I told, we need to do the lab investigation so that other complications can be ruled out. So look for diabetes, dyslipidemia, NASH, hyperuricemia, rheumatoid hypothyroidism, and endocrine evaluation if indicated, like for PCOS or the Cushing's we need to evaluate. And cardiovascular evaluation to rule out any underlying coronary artery disease is there. Ultrasound abdomen mainly for NASH, renal stone disease, gallstone disease, and in female for PCOS, and polysomnography if there is a history of OSA. So identify the candidate based on this. So little or no risk means BMI is normal. For Indian population is less than 23, and if they need to maintain the weight. That's again very important. Maintaining weight is also not very easy. So those people also have to follow the healthy diet and do physical activity to maintain the weight. That's also important. Low risk means BMI 25 to 30. In Indian population 25, you can reduce to 2.5. So 23 to 27. Who don't have any risk factors for cardiovascular disease, other comorbidities, then we can go for only diet and physical activity. Moderate risk means 23 to 27 with risk factors or BMI more than 27 for Indian population. Then in this population, along with this diet, physical activity and behavioral modification, pharmacotherapy can be initiated. High risk means in Indian population, anything BMI more than 30 or 35 with multiple risk factors or BMI more than 35, then we can also give an option of bariatric surgery for those patients. So we need, based on this history and investigations, then we need to categorize the patient to no risk, little risk, moderate risk or high risk patients. So based on this, the management will be there. So for management, we have this dietary modification, physical activity, behavioral modification, then drug and then surgery. The first three are very important. They are the pillars for the management of obesity. So diet, lot of different diets are there. So balanced deficit diet is around 1500 kilocalories per day. Low calorie diet is 800 to 1500 kilocalories. Very low calorie diet is less than 800 calories. Very low calorie diet is also like Atkins or keto diet, where they take less than 400 kilocalories per day. Most important is energy deficit. So again, this has to be explained to the patient. If the patient reduces 7000 to 7005 kilocalories over time, they lose 1 kg. So average 500 kilocalories per day. If they have the negative balance, they will lose 2 kgs in a month. So this they have to do consistently. Most of our patients will follow. For 5 days they follow, 2 days they will have biryani, all those things. Everything will get neutralized. So unless if you take the history properly, if you dig out the history, most people will not tell us. They talk about the 5 days only, they will not talk about the 2 days. So we need to ask them repeatedly, then they comment. So most of them, they will have a neutral energy intake, so the weight, they will not have weight loss. So one of the common cause for resistance to the diet and physical activity. And total energy intake matters more than the macronutrient composition, like low fat or low carbohydrate. So many data shows that if they are followed up for a long time, almost the weight loss is equal between the low fat or low carbohydrate diet. So overall, the energy deficit is very important. And low carbohydrate diets, the average they lose 8% weight loss in 16 to 26, and very low carbohydrate diet like less than 800 calories, 15 to 20% in 12 to 16 weeks. But if you see after 1 year, it's almost similar, the weight loss will be, because the body will adapt to this one, changes. What will happen is the body will reduce the resting energy expenditure. So after sometimes many people who follow this religiously, they will have practice. The reason is there will be a reduction in the resting energy expenditure. So ultimately, if they follow 400 and 800,000, there will be equal weight loss. So thing is, the best thing is educate them and ask them to have a 500 kilocalories negative balance every day, that will be better. And yo-yo phenomenon is common, particularly with a very low calorie diet. If they follow and suddenly stop it, there will be a rebound increase in the weight gain. So that has to be explained to the patient. Other dietary patterns such as intermittent fasting are sometimes used to promote weight loss, but the evidence for efficacy is mixed. We can advocate that it's for short term. For example, if the patient is planning to go for surgery for knee replacement or some other surgery, transplantation. Acute short term, if you want to have weight loss, it can be advised scientifically. Otherwise, for long term, we don't have the long term results.
So intermittent fasting should not be taken for a long time.
We don't have the evidence. The evidence are mixed.
No, but it can be continued, no?
But the thing is, it's very difficult to continue. But long term data, we don't have. That's what I'm telling. Scientifically, if they follow it for 7 years, 8 years, we don't know what will be the result. Any complications happen, we don't know those things.
What is the complication that is going to happen? 16 hours fasting you are going to do. What is the complication?
We don't know. That's what I'm saying. We don't have the data. We have 1 year, 2 years data, but we don't have long term data about it. So the other data, we have no candidate, all those things we have, but for this, we don't have the long term data.
What about paleo diet?
Finally, I think the macronutrient composition doesn't matter. It's more with the energy deficient is more important. So again, see the palatability, whether the people will be able to continue, all those things also very important. I'm coming to that point. So all those things also has to be considered while choosing the diet. Because many times they follow the paleo diet and they will not be able to continue because of the taste, all those things. Again, they will stop it and be rebound weight gain. So everything has to be considered. The likability for the food, whether they are able to continue, all those things has to be considered. So I am coming to that. So no single diet fits all patients. So the goal of dietary therapy is reduce the total number of calories consumed overall, and choose a dietary pattern of healthy foods rather than focusing on a specific nutrient like the low fat or low carbohydrate. It should be all healthy foods like the Mediterranean diet. And patients often need guidance in choosing their dietary strategy. So we have to choose according to the usual eating habit, food preferences, and preferred learning style and capabilities, and pursue the ability to manage hunger, sustain adherence, and maintain the pressure of eating. What I used to say to my patient is commitment and consistency. These two C are very, very important if you want to have a continuous weight loss and also maintaining the weight loss. So for that, moderation is better rather than to go for extreme. Because many people used to follow for some time, then they used to stop their diet or physical activity and they come with the report. So rather than that, consistency and the commitment is important. So always the moderation, whatever they used to take, in that it's better to modify rather than to go for a extreme diet. And dietary adherence is very, very important predictor of weight loss. And compared to diet, physical activity actually doesn't contribute much to the weight loss. The diet modification is very, very important in the weight loss, but physical activity is very, very important because it preserves the fat-free mass. For improving the muscle mass, it's very, very important, and also it maintains the resting energy expenditure. With diet, I told, with following the diet for long time, there will be a reduction in the resting energy expenditure, but physical activity maintains the resting energy expenditure, and also it enhances the insulin independent glucose uptake. So the patient has to walk for 4.5 miles per day for 15 days to have 1 kg weight loss. And 10% of the weight loss significantly improves the metabolic profile and blood pressure. So diet modification is very, very important. Along with the physical activities has to be done for this additional benefit like improvement in muscle mass and maintaining the REE, and also maintaining the weight whatever the patient has lost. For maintaining the weight loss, physical activity is very, very important. They have to continue the physical activity. Behavioral modification is very, very important. Patient counseling, we frequent psychologist counseling is very, very important because they have to understand what the process they are going, and they have to control it. If they are going for party, anything else, they have to control themselves. So all those things, the counseling is very, very important. Pharmacotherapy, sorry for the busy slide, but at present the most effective molecules is GLP-1 receptor analogs. We have injectable semaglutide in India, and in oral semaglutide we don't have injectable semaglutide. Other than this, we have orlistat. So at present in India only we have these two options, GLP-1 receptor analogs and the orlistat. So data says that the injectable semaglutide has a very good weight loss, almost 14% weight loss compared to other molecules. Liraglutide has 6% weight loss. But we have a new molecule. It has been introduced in the US. Tirzepatide. It is a combined GLP-1 and GLP-1 analog. So that's excellent weight loss. Almost if we see, almost 50% of the people are having weight loss at the end of 6 months. So almost 20% of the 50% of the people are having 20 to 25% of the weight loss at the end of 6 months.
How does it work?
It's a GLP-1 and GLP-1 receptor analog. Almost similar to GLP-1 receptor analog.
It just suppresses appetite.
Suppress appetite, other it increases the GLP-1 level in the body. It accepts the neurotransmitter levels also. So significant anti-diabetic molecule has a good weight loss effect. So excellent molecule, probably in 1 or 2 years we may get it.
In metformin also they say it reduces weight.
Again, people with insulin resistance, by giving metformin, it reduces the insulin level. So it helps, whatever the effort patient put, it helps in having the better response. So because insulin will not allow us to, it's a strong anabolic hormone, so that may be resistant to weight loss. So it helps in boosting the whatever they are doing.
This is advisable for children, sir.
Metformin, sir.
Obese children.
I don't know about pediatrics. Any idea, madam? Kids, children who have tirzepatide in children.
No, but it has just, I've seen the headlines today that they're applying for an independent license for obesity management apart from its diabetes indication.
For adults.
FDA is fast tracking it, but only for adults over the age of 18, not 15.
There's a big WhatsApp message going on that every time you eat, whatever you eat, even for 1 tumbler, 1 glass of milk or coffee, 4 units of insulin is secreted. Is it a fact that if you take full meal, 4 units, and if you take even 1 small bite, 4 units is secreted. So that can aggravate obesity.
Milk you are
Anything, any food, intermittent eating aggravates insulin production, and that can cause obesity.
It depends on the food what you are taking.
No, insulin production is independent of whatever food.
There will be basal insulin secretion throughout the day. There will be basal insulin secretion. There will be pulsatile secretion based on the food what content you eat. Accordingly, it will be secreted.
So it is not based on just like.
No, basal pulsatile secretion will be there throughout the day. So and there will be pulsatile secretion after the food intake. Depends on the calorie intake only.
In fact, intermittent diet itself was formulated only because of this. They said because insulin production comes with any food. So don't take any food, only 2 food if you take, only 8 units per day will be secreted, so your hyperinsulinism will not be there.
No. Even in fasting, there will be pulsatile secretion will be there. It means basal secretion will be there. That will be there. There are few devices are there. In India, we have this laparoscopical adjustable gastric banding and intragastric balloon system, where the patient doesn't want to go for this surgical procedure, they can go for this procedure. The weight loss will be slightly less compared to the bariatric surgery, 10 to 20% they can have. And bariatric surgery, we have restrictive procedures and mod-absorptive procedures. Mod-absorptive procedures they will have more weight loss compared to the restrictive procedure, but the side effects are more. And bariatric surgery usually it's indicated BMI in Indian people with BMI more than 30 with comorbidities and BMI more than 35 without comorbidities, and documented failures after non-surgical procedures or the non-surgical interventions. The most important thing is the patient should be committed to the lifestyle changes. Unless the patient is not committed, again the bariatric surgery may fail. So usually 20 to 40 kg weight loss can be expected, and they will have other benefits also. Remission of diabetes. Swedish obesity study has shown that almost diabetic remission happens in 72% at the end of 2 years and 50% at the end of 1 year. Hypertension improvement, lipid improvement, weight improvement also can happen with the bariatric surgery. Side effects are important. They can have anastomotic leak, peritonitis, malabsorption. Again, very important. You have to take micro and macronutrient, particularly after the malabsorptive surgery. Dumping syndrome, rarely in acidoblastosis, that is a post-bariatric surgery, the patient can present with recurrent hypoglycemia. That is non-insulinoma, pancreatitis, hypoglycemic syndrome can happen after bariatric surgery. So to conclude, obesity is a global epidemic. In India, again, the trend is increasing, particularly the childhood obesity. And the Tamil Nadu showed data 10 years back, almost 25% in Tamil Nadu, the prevalence of overweight and obesity. So the definitions are different based on BMI or waist circumference or body fat, but usually we follow BMI and waist circumference in population, and again the definitions are different for Asian Indians compared to the Western population. Lifestyle modification, dietary modification, physical activity and behavioral modifications are the mainstay of treatment. And in indicated patients, even after this adequately treated, if the BMI is more they have comorbidities, then you can go for the medical treatment. At present, available therapy, GLP-1 receptors or analogs are potent, but it's costlier. And we have injectable, and now oral therapy is available, but still it's not indicated for weight loss. And we have another option is Vorlicet, but again it's not a very magical drug for Indian population because our fat intake is not very much compared to the Western population. So bariatric surgery again may be rewarding, but again the cost factor, the patient, the morbidity associated with bariatric surgery also has to be considered. Thank you. Thanks for the question.
How often do you use GLP analogs? Not common.
Affordable patients use. Common.
How expensive is it?
Approximately around 10,000 rupees per month.
Okay, 10,000.
10,000 approximately.
So regarding obesity, any difference between the central obesity and peripheral obesity?
That's very important. That's why the waist circumference, the data is also different.
So if you consider central obesity, is biomedical impedance analysis very important or CT analysis?
We don't subject the patient for all those things because clinically we make the diagnosis. Clinically itself we can make the diagnosis of insulin resistance by agandosis nigricans by measuring the weight circumference. So we don't subject the patient for the DEXA scan or those things for the fat analysis. Usually we don't do, but it's simple as a bioimpedance that easily we can do it in our clinical practice itself. But again, there is a lot of variation used to happen with the bioimpedance itself. The reproducibility rate is very less. So rather than going for this, practically clinical examination and history, that itself will give a lot of information.
DEXA scan is not very useful.
We don't do it routinely for this purpose.
Well, that is exactly the amount of fat.
Yes, but routinely we don't do that. As I told you, clinically itself we can
In GLP-1
one concept of awareness. In a non-diabetic obese person, with taking decrease of blood glucose level.
It's a glucose dependent insulin secretion, so it doesn't cause hypoglycemia. It's safer to use. And we use for diabetes 1.8 milligram only, but obesity 3 milligram is a higher dose for obesity.
First of all, I just wanted to thank Sundar for coming here today, and I wanted to make a couple of points. When you were asking about the microbiome, there are actually very interesting studies showing that if you use antibiotics more than 4 times a year, it more than doubles your risk of diabetes. So the gut microbiome basically determines a lot of our metabolic balance. There is a lot of work being done about it, and like Sundar said, they are trying to look at the gut microbiome in obese people is different from the gut microbiome in thin people. In rats, they've done studies where they've taken this microbiome and put it into that and that into this and showed that it makes a difference. So thin rats become obese and obese rats become thin with the microbiome itself.
But antibiotics are not allowed in US. It's not across the counter. Antibiotics is so difficult to get in US and UK. But obesity is higher there. Here antibiotics are available across the counter.
No, I mean, that's one of the factors. Obviously in the US it's because, so many other reasons. I'm just saying, just to answer.
No, but I think antibiotics are it's going to cause havoc in India because it's just available for a song.
That's why, in fact, I think, when we deal with obesity, I think prevention is best. And, we have to constantly, the place where I see people gaining weight is really in the late teen years. A lot of young girls, particularly 10th standard, 12th standard. For boys, it tends to happen, I think, a little bit later, around mid-20s, or when they get married. That's when their weight gain occurs. For girls, it happens earlier. I think it's a combination of stress and lack of exercise, the usual things, what we were talking about, environmental factors. But prevention is key. Once they gain that weight, and then in pregnancy, one pregnancy they gain 10. Second pregnancy, they gain another 10 to 12. They don't lose it. So it's very easy for us. One of the first questions I ask when women come in with obesity, what was your weight at the time of marriage? Invariably, they'll be 30 to 40 kilos lighter. They'll come in with some 100 kilos, 102 kilos. What was your weight at the time of marriage? 60 kilos. Invariably. And this just builds up over the years. So that prevention is key. And also telling them...
Women tend to eat more after marriage, is it?
Men tend to eat more after marriage.
It's mathematics again. It's energy expenditure versus energy intake. So we don't do that actually. So that's the problem. Probably this has to happen from the school itself. The education, all those things, the healthy intake and the energy expenditure, they should start teaching the school.
Endocrine society should tell the Indian government that they should stop supplying antibiotics across the counter. If antibiotics is going to, if you take 4 antibiotics in the course of a year, if it's going to cause diabetes, then I think you have all the reason to tell the pharmaceutical industries to stop issuing antibiotics across the
so
counter.
many things. Where will we draw the line? Stop selling sugar through the ration shops. That is considered a very serious matter. Don't give access to sugar at subsidized rates.
See, you can do it. If individually, I never give a sweet to any of my relatives during this thing. I only give them karam. I don't give them sweet at all. So make everybody like
Everyday newspaper first page, if you buy for 2000, there's only 1 packet will be free. That's the ad in the everyday newspaper first page.
Let them do it, but at least individually, if you take don't give sweets as gifts. Sweet as I told, it's the social or environmental factors is a different topic, and it starts from the microenvironment to the government. So many people are involved. It's very difficult to address that unless, like a stop tobacco, it started happening 1 or 2 decades back. Now it's picking up. So similarly, the programs should happen for the obesity also. Obesity is a killer. So if only the endocrine people can tell the government about this.
I think it can start with us. Just on a lighter note, I want to add about 10 years ago at one of Dr. Momin's meetings, he said he was going to give a low-calorie lunch. It was some 300 or 400 calories, I can't remember, one packed lunch, just one sandwich, a fruit and some, I think, one drink. There was some feed. There was so much of resistance. Doctors hated it. It was a doctor's conference, his biannual conference, whatever it was. They were very angry. Why are you giving us food like this? So I think it has to start with us. All of us.
Yes, yes.
Not just us going and telling one
So the
person.
lunch which is given here should not be done.
Not at all. Not at all. Not at all.
So
Or at least
for
you can do the
next
lunch
meeting,
now.
no lunch for everybody.
Or if you have a good lunch here, skip
You
dinner.
don't need the tea.
Yes,
You certainly don't need the tea after, right?
exactly. But it has to start with us.
So how we have to make a
How
beginning?
to avoid antibiotics? Can we see a prescription without antibiotic?
No,
Not
at least,
one,
see,
3 or
doctor,
4.
see, doctor eating antibiotics also is bad, too much of antibiotics. But
People buying it on their own.
patients say, I finished azithromycin in 3 days. He comes to me only after finishing it. What is the point?
But common practice in the, in the common practice is dietary intake and expenditure. That is a common factor, is misjudged and misdirected. I think, as you said, the diet is the most prevalent factor, and our behavior. When you see something, you jump on it.
I still feel the Indian women mothers are spoiling our kids.
No, it's not like
They
that, sir.
only
It's a
won't
mutual,
feed the
sir.
children. I've never seen a mother saying my child is eating properly.
Well, I don't think you can blame only the mother.
Mother, yeah. No. A lot of discipline is required.
Doc, please 1 minute, 1 minute.
Thank you, Dr.